Okay, let's get started. Welcome to today's webinar, Practical Applications of Functional Neurology, a part 2 of Heads Up, Exploring Concussion Injuries and How to Best Support the Injured Worker's Recovery. That was a session hosted by Medical and Life Care Consulting Services in our 2022 Injury Insight series. We do invite you to take a look at that session if you've missed it. Medical and Life Care Consulting Services is a case management and nurse consulting firm headquartered in Massachusetts. And in collaboration today with Dr. Jishua Helm of Greater Boston Performance Care and ChiroPro Performance Center. We're excited you've joined us for this presentation. My name is 𝐏𝐻𝐿𝐿𝐥𝐢𝐜𝐚𝐥 and I'm the moderator for today's webinar. This webinar is anticipated to run 50 minutes with an additional 10 minutes for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay along with a link to a short survey, which will also show in the end of this presentation. We do ask that you take a moment to complete the survey. Your feedback is valuable and helps us in planning our educational resources. We are excited to host today's webinar and do look forward to an opportunity to partner with you. But to kick it off, I'll pass it to our host, Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, often referred to as MLCC, and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Cindy, over to you.
Hi, everyone. Thank you for joining us today. Now, just as I do at the beginning of each of these webinars, I just want to share a little bit about Injury Insight program. It is now finishing its 3rd year, and we have had excellent response to it nationwide, and so we're really excited about that. But you're probably sick of hearing me talk about it, but I'm going to go through it one more time. Injury Insight is a 4-part webinar series, and it's designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments both common and uncommon within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help all of you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So, as always, get your questions ready at the end of this webinar. And I'm very excited that and grateful that Dr. Helm, who is our presenter today, has agreed to come back to work with us to extend his talk. There were so many questions after his last presentation in 2022 that I'm very excited to see this presentation today, which is a continuation of that. In this session, our guest speaker will walk us through a clinical experience as he highlights diagnostic and therapeutic equipment, as well as treatment strategies for patients suffering with traumatic brain injuries. As shared earlier, this session is a follow-up to his 2022 session on concussions and will help us gain a deeper understanding of diagnostics and treatment methods of traumatic brain injuries and features several real-life case studies. For this session, Practical Applications of Functional Neurology, we're pleased to have specialist Dr. Jishua Helm of Greater Boston Performance Care and ChiroPro Performance Center join us for part 2 of his last session. Dr. Helm has served as clinic director for over 5 years with a primary focus on sports injuries, concussion rehabilitation, functional neurology, vestibular and autonomic disorders. He completed his clinical education through the U.S. Department of Veterans Affairs in Western New York, where he was first exposed to brain-based treatment strategies and the exceptional nuance in patient outcomes. Dr. Helm acquired his board certification for the American Chiropractic Neurology Board in 2020. The neurological aspects of care and its effects on the recovering athlete has always been a crucial focus of Dr. Helm's in creating lasting improvements with his patients. He's completed additional extensive postdoctoral training in dysautonomia, vestibular rehabilitation, and movement disorders through the 𝐏𝐻𝐿 Institute of Graduate Studies. Growing up in Bethlehem, New York, he found his lifelong passion for martial arts, Aikido, Judo, and Brazilian Jiu-Jitsu. Dr. Helm has made it his mission to find the most effective treatment strategies to bring individuals out of pain and dysfunction and back to doing what they love. In his free time, Dr. Helm enjoys spending time with his wife, and his wife was first, and his dog, Ori. So take it away, Dr. Helm.
All right, guys, I can pick it up from there. Cindy, thank you so much for that introduction. I think that was from last year. So my puppy is now full grown into a dog, which is great. So what I'd like to do, guys, is reconnect on these initial slides here from last year. It'll take me, I'm anticipating about 5 minutes to get through this. I, of course, invite you to the old seminar to review those slides. If that's at all helpful to anybody, I don't intend to reinvent the wheel here, but I think it will be a great point of orientation if I could revisit each slide individually. So we discussed neuroplasticity, the ability of the nervous system to respond to intrinsic and extrinsic stimuli in our environment. Basically, we hear the old adage, what wires together, fires together, right? So we have this ability to change our brain based on novel input, and that input is helpful for us to adapt in the future. So our brain is constantly changing and adapting with everything that happens in our life. And what we want to do with care is get as specific as possible with those interventions to help the brain shape and change in the way we want it to permit improved function. So all right. So we talked about the brain being concerned with two questions. Where am I in my environment? Where is my environment relative to me? So our brain's obsessed with safety. It's always assessing, am I safe? How much autonomic arousal should I have to feel good in my environment? We hope that that is set low, but occasionally people feel wound up or more excited by their environment than they should. And it usually goes back to these two questions. We discussed the sensory inputs that are necessary and important for our brain to assess our safety, the visual system, the vestibular system, and the proprioceptive system. We discussed how they work together and integrate and have to tell the same story so that we can map our world accurately. And when they do not tell the same story, or one of the systems is not playing nice with the other, we discussed how that can create a sensory mismatch, and that can create problems in our world, distortions in perception, as well as compensations in the structural anatomy of our bodies. We talked about the human brain and how much is dedicated to the brainstem in terms of rehabilitative techniques and strategies. In decades past, there was a lot of focus on the cortical regions of our brain in terms of executive functionality, parietal and temporal distributions of both time and space. And a lot of the modern day rehabilitative strategies have moved to the brainstem due to the autonomic integration there that happens, which is our sense of ourselves in terms of blood flow in our body, as well as the vestibular and visual centers are all down in the brainstem. So a lot of the most impactful basic therapies can be utilized and implemented lower in the brainstem. So we do that for efficacy, so patients do better with the more basic functions. I always make the crude analogy about how you can cut a chicken's head off and it can still run around. So we know that these autonomic centers, these most basic life functions, are lower in the brainstem. So the amount of real estate that is devoted to that is crucial, and we have to start with that for care. We talked about sighted blind and the different ways our brain adapts to trauma. We discussed how the visual system is integrated, how much of our brain is dedicated to the visual system, both in terms of color and spatial orientation, but also field of view, vertical axis. All that can be reviewed in the prior presentation. We discussed an example of the Troxler Effect, which is a rehabilitative technique for patients to use to create gaze stability, where they're staring at the central crosshairs. And basically, we're looking to imagine that green dot moving around, inhibiting the ability to see the purple or the pink dots. And that green dot is not actually there, but it is an effect that is created when we are able to gaze stabilize. This is a way to give patients real-time feedback about how well they can keep their eyes still. It was one example of gaze stability. We talked about the vestibular system and how that works in terms of the otoliths and the semicircular canals in the inner ear. We talked about the commonality between those sharing the same nerve as the cochlear distributions from the hearing in our inner ear. So that's available to you in picture form there. We discussed vestibular therapies that exist. This is Mark, a multi-axis rotational chair. This patient is going to be spun into a certain canal preference, a positional distribution that is helpful for her to attenuate her asymmetry of her feedback from her inner ear. So this is an example of more of a high-tech therapy that's available. Some clinics simply use a chair. Works great. We talked about proprioception, which is our sense of awareness of ourself in space. If I close my eyes right now, I know I'm seated. How do I know that? I don't know, I just do. That is proprioception, and we use that to help layer in types of vibration and hot cold therapies to help patients integrate their sensations. We talk about the overview of autonomics, which is, again, that blood flow perspective and the overall effect in posture. We talked about stacking receptors. So we always do multiple therapies at the same time to create novelty and intensity, so patients are able to adapt faster through therapy. We discussed the nutritional components and talked about inflammation and, of course, consumption from a macro perspective. We talked about examples of antioxidants like Cogniquil, EPA and DHA, fats. We talked about vitamin D and discussed protein macros. There are patients that come into us anemic or very inflamed or B12 deficient. All of that stuff is incorporated and thought about in care to make sure that their body is set up to receive the most optimal care possible. Glutathione is an example of an antioxidant that is utilized a lot in brain injury rehabilitation. This brand Zymogen is exceptional with their product. I hope that was quick. I wanted to blast through that to get us to the meat and potatoes of today. We got a lot of feedback last time about we needed more concrete examples, case studies. People were interested. They got the concept, but they just didn't understand what was happening here at the clinic. They wanted to see the ins and outs of several case studies and kind of highlight the equipment that's being utilized. I think it'll create a more clear picture. So just as a macro perspective, I'm going to present 7 cases to you all. So just mentally prepare for that. And I'm going to do my best to parse them into appropriate amount of time. They're really dense cases, and I appreciate your patience with the slides. It's a lot to cover. I think it's all important information, and you'll see why. I wanted to remind everyone last time of this visual midline shift case. This individual came to us, workers' compensation case, with what presented as a strabismus. It was in her notes as an esophoric presentation of her left eye. You can see it there visually. Hopefully, I'm not blocking my own slides with this. I'm going to hide my image. But you can see the visual midline shift. The eye has come in. I pointed out to everybody that this is not a lazy eye or a strabismus. There's no muscle weakness here in the eye. We discussed how the eye is pinned in relative to a vestibular function in the inner ear. And I just wanted to appreciate the fact that the required therapy for this was a spin intervention on a chair, which was helpful for her to bring her eye to midline. So we didn't have to patch her eye or do any type of vision therapy directly. And the point was simply to note what appropriate therapy is used for a case based on what is most helpful for them and the required workup with that. This is an example of our clinic treatment. I wanted to highlight a couple avenues here to hopefully make things a bit more tangible. In the clinic, we do an incredibly thorough eval, which takes 2.5 hours. Several of the nurse case managers that currently sent to us can attest to how detailed and thorough the eval is. We really dive deep because the cookie cutter approach does not work in any regard for neuroplasticity as well as this type of care. So it really does require a lot of very detailed assessments to really serve the patients at the highest level. This is Dr. Anderson in the top corner. She's using what's looks like an ophthalmoscope, excuse me, and she's holding a Maddox rod. That is a prism lens that we have over the patient's eye, and that is a technique we use to compare the visual alignment of the two eyes together. The prism allows us to appreciate if there is a movement of the eye off center relative to the other eye. You can imagine the case before would have shown a positive on this test. What attenuates the visual alignment, it matters a great deal. For instance, if the neck position is effective or eyes gaze to the side, up, down, convergence mechanisms. And depending on what attenuates or brings the eyes into a normal position it can be very telling for the strategy we want to use to proceed. Just below that is a NSI, a neurosensory integrator. This is a touchscreen board. This patient is playing a game with her visual spatial mapping where the board is rotating in a clockwise direction, and it's designed to help her eye with the torsional aspect that she's missing. This is an example of the level of detail we need to use to help this patient. Just below her, we have an example of a patient working on gaze stability. This patient is being spun in a chair and with a pitch plane backward while they visually fixate on that red dot. What we're trying to do here is inhibit a natural reflex to move our eyes. Our eyes are beating in reaction to movement, which is called the vestibular ocular reflex. And there's a great deal of functions that come from being able to inhibit that reflex on demand. So, you're walking in the mall, you're driving in the car, we have to be able to keep our eyes still despite movement. This patient was struggling with that to a great deal, so we had to practice it. So what we do is slow the therapy down to a doable and achievable level. Also pictured there is the V-light or V-light. This is biophotomodulation helmet that he's wearing. Those are lasers pointed at his head. The research on biophotomodulation is important for mitochondrial uptake, energy production. It allows our patients to do a little bit more rehab in one go, a little bit more fuel, a little bit more wherewithal for care. Pictured in the middle there is myself actually working on a patient that is gaze fixated on that same red ball. You can see I'm utilizing what's called RPSS. This is rapid peripheral somatosensory stim. It's a electric modality that goes on the cheek, and it offers the stimulus into the pons, which is part of our brainstem, which is very closely associated with our eighth cranial nerve, which is controlling our vestibulocochlear involvement from the inner ear. So the reason that matters is because the stimulus on the cheek from the trigeminal nerve moves and affects the eye stability in a way that it creates the sensation of wanting to move your eyes off center. And the active fighting of that, where the patient, it's like doing push-ups for your eyes, has to keep their eyes engaged on target despite the proclivity to want to move, will create the appropriate stability that's needed. This is an example of an extremely gentle therapy that is, say this patient cannot tolerate spin or some type of other more intense treatment. This patient can simply lay down and still get the same effect of having a challenge offered to their visual system and actively fighting to inhibit that. To the right of that, we have pictured the 𝐏𝐿-CONIA. This is a class 2 laser. This is used, again, for energy production, often for headaches. We can get therapy done in shorter periods of time with more energy production. This is on a chronic fatigue setting, which is utilized a lot, as you can imagine, for patients. Again, I recognize the density of these slides, and I apologize. I do want to cover a few different modalities I think would be helpful and impactful for for us to understand. Then the top left there is the computerized posturography that is called CAPS. It's the gold standard for balance assessment. With our patients, we put them in perturbed surface testing, hard surface, different head positions, eyes open, eyes closed. And what we're looking for is to assess where the breakdown is in balance and why, and thus a angle of strategy with regard to care. So the printouts on these are pretty objective and gives us kind of a benchmark to compare before and after care and understanding the balance progress there. I'm going to show you several examples of this later. To the right of that is the video nystagmography, VNG. Video nystagmography is again, recognized as the gold standard for visual assessment. This is going to be used by your ear, nose, and throat for basic vestibular function. It allows us to check movement of the eyes, both speed and accuracy, latency. Classic signs of concussion will come out on these tests. We're able to observe the eyes in pitch black with infrared technology, so we can see the proclivity for movement when there's no stimulus, which is super important and helpful in terms of care. We're also able to give visual stimulus in a certain direction as pictured there and see how the eyes can react. This type of data is incredibly objective and very helpful for mapping progress for patients in terms of visual and vestibular function after an injury. Next to that is the motion guidance. It's a neck and proprioceptive integration. So you're able to put a laser on someone's head and have them look at a target. And basically it gives the patient an immediate awareness of a difference between what they're seeing and what they feel, where they feel their body is in space. So it gives them that real world feedback. For instance, if they think their head's to the left and they can see the lasers pointed to the right, they can get a sense that their perception of where their body is not accurate, which is very helpful for rehabilitation. Next to that is the RPSS, which we had already pictured. Below this, an important couple extra here. This is interactive metronome. This is a young boy. I believe he's golfing. Excellent. So that is metronome activity is a timing and sequencing based rehabilitative strategy where the patient can time and clap or move their body as accurately as possible to a beat. It is a predictable rhythmic beat, and they get real live feedback regarding early and late. So they can self-correct and attenuate to a normal beat response as appropriately as possible. And the error correction mechanism that happens there it turns out to be researched for OCD and various motor-related issues, Parkinson's, certainly cognitive, motor planning, memory. We see it a lot in autism spectrum disorder. We use it a lot for our concussions. So in terms of development, it's wonderful for the kids. It's interactive, and we appreciate using it a lot. I'm going to point out a couple more. The D2 to the right of that is our light board. This is a visual spatial accuracy technique. We're able to train patients on the board to improve their spatial awareness as well as their accuracy in moving to that target. A lot of our understood unsettledness feelings in our body, whether it's anxiety or what have you, we understand that a lot of these patients have breakdowns in their ability to perceive their world in terms of accurate and quickly. So tasks and games like this are helpful to improve these patients that have, for instance, a poor finger to nose test, right? Spatial issues. Maybe they're unaware of their arm position or are missing a part of their visual field due to hemianopsias or strokes. This is all highly relevant for that. I had a couple other examples here. The Phoenix Wave is going to be more of your standard direct musculoskeletal treatment. So is same with neurofunctional dry needling. I want you to appreciate that we don't neglect the musculoskeletal component of care. It's one part of an overarching treatment strategy. I want to jump right into these case studies. We have 7, as I mentioned. The point of this first one is to illustrate the connection and cohesiveness between all of the systems and how the depth and breadth of all concussion rehabilitation cannot be simplified into, one bucket or one strategy. I also just would like to point out that all these individuals are patients first, and they have a story. And no one, as we know, as case managers, are are treated in a bubble or can be boiled down to just one injury. And all of us have prior histories and conditions and what have you. And in order to help somebody with their concussion, you just have to address all of it. Unfortunately, there's no way to separate out those things. So we're looking at a 28-year-old female, history of supraventricular tachycardia, postural orthostatic tachycardia. This is referred to as POTS, if anybody is familiar with the buzzword. Basically, I'm describing your patient that when they stand up, they get dizzy, their heart rate takes off, right? We've all seen these people. They tend to be high anxiety. They tend to have, a dysregulated autonomic, so blood flow problems, Raynaud's in the hands, GI motility issues. As I mentioned, they might be a bit nervous or disoriented in their world. They have endocrine problems, adrenal issues, anywhere where blood goes, which is everywhere, right? So this poor woman has had headaches and dizziness and nausea. The issue with this is that she has a post-exertional headache where she doesn't feel symptoms in the moment, but 6 or 8 hours later, she really is down and out. And it's discouraging because it's hard to tell where her lines are, where, what's too much. So this is an example of someone who's extremely healthy. You would love to have as a patient because she's hitting the boxes metabolically. She has no underlying condition. She's not diabetic. She's eats well, exercises, right? So she's been everywhere. And the point here is that she couldn't get the care she needed, and I wanted to explain why. So her autonomic system is dysregulated. We discussed her heart rate spiking. The reason that it's doing that is, although partly autonomic, but the systems that it calls on to normalize a heart rate response are the visual and vestibular systems. And it's very important that those systems are online and working appropriately so we can gauge a normal response for our heart, so our body and brain can do the correct job for what it's perceiving in the world. So if we're not perceiving our world correctly, we're not mounting the appropriate response. It raises anxiety, it makes us unsettled, and it makes us stressed. So this is an example of what's happening with this patient from a visual perspective that, when corrected, will continue to demonstrate progress for her symptoms. So this is an example of a VOR test, just a couple of points of orientation. I'm spinning her in a chair, and we're looking at her eye movement. There is a reflex called the vestibular ocular reflex. When we spin somebody, you're looking for beat reactivity. The eyes are supposed to move in response to the perceived movement in the inner ear. The eyes are going to shift. We need to be able to suppress that reflex on occasion, as previously discussed. The ability to do that is paramount for feeling stable, safe in our world. So this person is looking at a target on roughly 2.5 feet in front of her, and I'm spinning her in the chair rightward and then leftward. I'll explain as we go. Neither direction she is able to keep her eyes still. We're seeing excessive movement despite the intention to keep her eyes still on this target. I want to explain, of course, how debilitating that is and what this could feel like. I'm just going to hit play here. So this is going rightward. You can see the eyes beat in reaction to that. And then here we go left. You can see the counterphase movement leftward. The ability for her to keep her eyes still here is extremely compromised. It reminds me of a graph of somebody that is completely not looking at anything. It's very close to the type of reaction you'd see if she was not fixated. And this is her trying to keep her eyes still. So this is, of course, problematic. We're seeing issues with anytime she moves her body in space, her eyes move excessively, both up, down, side to side. And this is creating a lot of issues for her heart rate. It creates stress and anxiety, which also raises her heart rate. And my point of showing you this case is just to appreciate how the visual system can impact blood flow and other findings like dizziness and nausea indirectly and directly. This is a second case study of a patient with MCAS. MCAS is mast cell activation syndrome. For those unfamiliar, it is a condition where we're seeing excessive response to environmental stimuli. There is a histamine response. Basically, everything we inject or put in our body, hot, cold, smell, what have you, becomes dysregulated. It can become dysregulated for the patient. So they're having an excessive histamine response, and their systems are becoming overwhelmed by what should be a normal stimuli and overreacting, and not the receptor that's responsible for creating the inflammation cascade is not turned off. So we're just getting more and more aggravated through environmental stimulus. These are the types of patients that, they walk in the bathroom and it smells like lemon, and they're just totally overwhelmed, and they get hives and have a migraine. We know these people, we may be these people. So the MCAS is no exception, and just trying to paint the picture of the type of patient here. These patients are often autonomically compromised, meaning they're having problems with blood pressures, heart rate, pulse oxygen. How they shunt blood in the body is aberrant. In the top right corner, we're seeing computerized posturography results. This is that balance test I discussed. You can see the sway patterns there, and you may be able to appreciate the orange writing that is moderately reduced. These are scores that suggest that the patient is moving excessively, more than they should for their peer group and demographic. And what I would like you to notice is that when their eyes are open on a hard surface, they do pretty well. They're mildly reduced. You can see that the first, I'm pointing with my pointer here. A test one on the right is nice and tight. However, when they close their eyes, the pattern expands significantly. And then again, on that third test. The second test is to suggest that the vestibular system is excessively taxed and compromised, because it gets worse when they close their eyes. The last test is to compare the visual and vestibular overlay, because we're removing the proprioception from the feet. And you can see that that's also a moderately reduced score. I would like you to know that for this patient, we spent most of the time working on the autonomic system. We were able to regulate her heart rate and blood pressure and her oxygen through breath training, tilt work, and other modalities that I previously mentioned in that report. And you can see several looks from August 21st. So this is September 13th. You can see the one on the left there, they're in the green now. And these are healthy scores for balance. And you can see that the sway patterns tightened significantly compared to the prior data, which suggests a better integration. This patient has improved balance. They're going to be more stable in their environment. They're going to feel less stressed about that. They're going to feel more centered, more hopeful, encouraged to continue. And the data is nice to use to show patient progress, but also to interpret how we're doing, right, with care. We should be making improvements in balance, in visual stability, and metabolics. Example of metabolics is all the way to the left. This is just a quick assessment we did to determine where things are being taxed viscerally for this patient. You can see the chemical tolerance lights up 87%, because everything in her environment she's reacting to in terms of inflammation, autoimmunity, and that is standard with MCAS. I would appreciate being able to go back to any of these that anyone has questions on. There's so much to share with these cases, but I think it's important to highlight kind of from a bird's eye view. This is the third case study, 62-year-old male, water skiing accident. He was water skiing. I don't know how many of you guys are water skiers, but 50 miles per hour is very fast, very fast. Ruptured his eardrum, not surprisingly. I wanted to show you more of this CAPS data to help us understand how he's progressing with his care. This first enlarged view shows 4 tests. These are head position tests. These are different than the tests that I just showed you. This has to do with the directionality of his head and how that affects his balance. So just point out that when his head's to the right, the side of impact, severely reduced score. But the most concerning position here is head extension. You can see test 4 has a profoundly reduced score at 18.5. This is virtually completely compromised. It's synonymous almost with having no integration of that position at all. The inner ear works to perceive bob, heave, and sway, also tilt, roll, and yaw, and several other integrations. So when we think about our head being backward, this patient does not have a sense of his balance when his head is backward at all, or virtually at all. which is extremely concerning both for future injury, but also for him to find stability in his current life. We have a situation where this gentleman closes his eyes and he feels excessive movement. His brain has not figured out how to regulate this yet. Imagine you're on an airplane and your one ear pops and how awkward that can feel temporarily. Imagine rupturing your eardrum and having your brain struggle with that pressure differential and not being able to figure it out. It's quite alarming and concerning. In the second chart there, we can see this patient approximately 2 weeks later. We spent a good deal of time working on that head back position, integrating and bringing online that canal for him so he can perceive that again and function to a higher degree. This is an example of real life, right? We're not doing miracles over here. We're just working on what needs to be worked on. So you can see that head position extension there has improved to a severely reduced score of 50.2. This is an example of a standard progress that we would like to see. We spent the time putting in the work with his head back, doing the rehabilitation that would improve that, and we're seeing an over 100% improvement in that position. Still a long way to go. He's not out of the woods by any means, but this is going to correlate with lower symptomatology, feeling better in his body. This case study 4 here, a 53-year-old male, recent concussion during a COVID positive. This is was included just to speak to the aspect before I was saying we don't get to treat people in a bubble. So when patients come in with us for a workplace injury, it doesn't mean anything other than they're attributing the injury to the concussion, but there's always a backstory. In this case, this gentleman happened to get COVID at exactly the same time. Just horribly unfortunate timing, I suppose. I want you to appreciate the square wave movement that we are seeing in this case. This is an example of the type of movement we see sometimes with viral or other aspects, things that affect the brainstem that create this standard square wave. I hit play here. You may be able to appreciate the eye movement back and forth, left to right. It's a pretty predictable and rhythmic movement of the eyes. It goes without saying, this is exhausting to do and certainly disorienting. The patient is not surprisingly anxious and unsettled, right? It would present that way. I'm sure you can imagine someone that is unable to keep their eyes still, the type of energy you'd receive from them in terms of anxiety and kind of baseline stress is high. So I want you to know how linked they are, in terms of being able to stabilize somebody's eyes and what that can do for them emotionally and into the future. This is the same patient after a week of, I think it was several days of what's called RPSS. So I showed you the photo of me doing the cheek stimulation. This is the video number 2 here. On the right, you can see the trend line at the top has smoothed out significantly. So we're getting far less chop of the eyes. You can see at the end where it picks up again, and you can appreciate that it's the same patient. There's a change in the function, but we're not out of the woods. And this is how it goes. So we get a positive plastic change. We're able to see and demonstrate to the patient and ourselves, hey, we're getting somewhere with regard to the function of this. We are getting your eyes to quiet down. We have way more work to go, but how does that feel, right? It's a check-in. And this is not necessarily permanent either. We've only done a few visits for this patient, but I have to confirm that we're heading in the right direction. I'm going to play this again for you. The trend line here is demonstrates a very slight left drift of the eyes, but there is a solid 10 to 15 seconds here without much chop at all, where the patient's not moving their eyes abruptly back and forth. And that is really what I wanted to demonstrate. Case study 5 is a young man. He has had 5 or 6 concussions. I put him in this presentation because of how specifically left-sided all of his symptoms were. I always find that interesting when we look at a hemispherical model, when the entire side of somebody, I'm sure you've all seen it in terms of case history, where it just seems like when one thing domino falls, the whole side just goes. And there's a reason for that neurologically, which we don't have to get into, but this patient is left pupil is dilated. He has a it's called an anisocoria or a 𝐏𝐫𝐚𝐿. You may be able to visualize that in this top video here, which I'll play in a moment. You really have to look carefully. You can see how that left pupil, which is actually on the right side, is slightly larger than the right. He has a left convergence insufficiency. His left eye is not unable to converge. And by that, I mean when we bring an object or our thumb towards his nose, left eye does not come in. He has a left temperature regulation problem. His hands get cold. His pulse ox drops on the left side. He has poor coordination on his left side. And his red saturation, which is the blood flow and the retinal perfusion of blood to the eye, is diminished. So this is all on the left side, largely perfectly normal on the right. So whenever we see a patient like that, it presents in a certain pattern, and the therapy has to take that into consideration. I'm going to play this first video here. You'll see the trend line. You guys are getting good at reading these now. You can see the red line drops off the dotted line. I know it's a tiny video, but you might be able to see how it slopes down. This is in the dark and pitch black. The patient can't see anything, and this is not something we'd ever be able to notice with our naked eye. But there is a downdrift. His eyes are moving downward over time. This is happening in the background to him all day long. It's an important finding because it creates disorientation and, frankly, feeling unsettled and unwell. It contributes to his symptoms and his headaches. It contributes to his disequilibrium. I wanted to show you on the second video here, you can see the red dotted line traces on top of the red line traces on top of the dotted line. And this is an example of an attenuation or a correction. You can see his eyes are no longer downdrifting. They're just staying nice and flat on that line. This is a preferred presentation for him. This is going to correlate with him feeling better. And it's important. It was an important progress for him. So I wanted to point that out. Depending on how much time we have, we can get into the weeds with these cases. There's a lot to nerd out here with regard to this last slide. With regard to the last video, these turning mechanisms were asymmetrical, and he had some findings with his velocity storage. I want to keep things surface level here. I just am trying to demonstrate the objective changes that are happening with patients in terms of their eyes and their balance and how that's affecting their symptoms. Generally, if we improve balance and improve gaze stability and get their eyes doing what they're supposed to, patients are going to feel better. Patients are going to report faster progress with their recoveries, and they're going to get back to work and back to their life. Case study 6 is an example of a patient. This is a workers' compensation case that we saw recently that had convergence insufficiency. This is, again, when someone cannot bring their eyes together. They're unable to converge. They can't bring their eyes in close to an object as it comes towards their face. This presents as a huge issue for, you can imagine, for computer work or daily tasks that require up close. The reason that this is happening is classically treated as a eye muscle weakness, and patients are often prescribed a bead string to help them bring their eyes together and work on that symmetrical convergence. I am purporting here that this patient essentially failed her PT bead string work because of an inner ear issue that was not discussed or caught. And it turns out she can converge completely fine when her head's tilted to the left side. Nobody knew that, and we didn't catch it until she came to see us. So there was an important lesson there, I think, for everybody. She would have been a lot farther along, I think, if someone had noticed that early on. But we have to look at the patient's ability to complete these tasks in various environments and in various ways, because usually we can stack the deck in their favor to make them successful, and then we slowly remove the crutches back so we can get them on track without any support. And this is a video of her. I'll play here. Her attempt to converge her eyes initially, and appreciate the trend lines again with the red the red lines, you can see how they trend together, and there's very little nuance to how they're moving. There's what I would consider to be no convergence there. In that first video, this patient has a long way to go, but after a week, you can see that there's a bolus forming in the second video here where it looks like a rounding is happening towards the end of the feed. This is an example of where her eyes were pinning together. She's starting to do the mechanism that's necessary to have her be able to stare at a computer and not fatigue, for example. Here we go with that. You can see this video playing. I try to pause it at the maximum moment where she's able to converge, which is right here. Maybe you guys can see how her eyes have come together a touch. This is far inferior to what is needed. She needs to be able to do much more convergence. This is just an example of her ability to do this is starting to come online due to a protocol which she was missing. Okay, case study 7. This is an 8-year-old, certainly not a workers' compensation case. I put her in here because I think it demonstrates these environmental factors that matter, especially for the young and developing brain. This young girl has attentional deficits, visual tracking issues, and learning challenges. She's really struggling in school to stay focused. It's affecting confidence. She's starting to avoid things that she shouldn't because she's embarrassed of her abilities. And it's not really her ability. She's quite cognitively sharp. It has to do with an issue in her ear, which I presume mom and I from possibly a virus as an even younger child, or a stomach bug, perhaps something that has compromised the integrity of the structure of her inner ear. These vestibular apparatuses are very, very sensitive to environmental triggers and toxins, and it's amazing just how delicate the structure is there and how rapidly things can kind of fall off the map. And I would like us not to look at things as so black and white, as everybody's on a gradient scale. We've all had environmental challenges in the past that have compromised our system, and the degree to which it happens, it's like eventually it becomes overwhelming and really in the way, and patients take it seriously. But it's not black and white. We've all had soft neurological changes to our body from environment. So this is an example of one we happen to catch because of how severe the symptoms got. In this first test, I want you to see her left eye and her right eye position. You can see here that I'll keep playing this on loop, but her right eye is deviating in pretty aggressively. This is in the dark. Difference here, this is a different equipment we're using, so she can visually fixate. But nonetheless, she's unaware she's doing this, and the right eye is pulling in pretty aggressively. What I'm doing to induce that is I'm tilting her head to the right side, which is the side of provocation, right? She avoids that. That's her symptomatic side. It creates the movement of her eye inward. When we tilt her to the left, it fixes it. It straightens her eyes out. So what I realized from a therapy perspective was this is a vestibular mediated issue. And we spent a lot of time turning her to the left and doing therapy for her left side and helping her integrate the inner ear sensation leftward, left and back. And what we did then is test her again with the same right tilt, the same aggravating factor, to see how she hangs in there. Are her eyes able to resist the urge to drop in a bit? And I would say yes. This is after 1 minute of work, and just to show and demonstrate how plastic our brains are. This is not permanent. This is not something I expect to last. It's just a test to understand what are this kid's capabilities with regard to recovery? What can I expect for a timeline? Would it make sense for mom and her to get out and about, do some fun stuff outside that involves her turning, right? Like what sports would make sense, all that. So here we go, test 2. You can see the right eye position already is more straight. You can see it drops in here, and this is through the provocation. You can see she's hanging in there a bit. She's squinting a little bit. If I were to pause you, I would say that right eye is a bit straighter than the initial test 1. If I were to compare, you can do your own analysis there. But that is just from spinning for a minute. We were able to see her right eye, straighten out a touch and resist the urge to drop in. And that is because of the known mechanism in her inner ear, her vestibular system. So this is, again, an example of something we wouldn't patch. We're not doing vision therapy, right? This is not going to respond to that. It may, but it's not going to fix the problem. She has an inner ear issue. And we had to do the work to find out what is the best therapy for her to fix this. It's not as simple as, strengthen the eye muscle or what have you. So those are all the cases there. I wanted to read this slide to you. Brain injury rehabilitation requires an ultra-specialized and individualized plan for each patient, an extremely thorough and detailed exam to best serve the patient and produce safe and effective results. When we work on the brain, we have to reinforce over and over and over again and stack novelty and continue to do the same care, but more thoughtfully each time to get them back to baseline. There's never been a single patient which we've treated exactly the same here. So I'm seeing, it's concerning to me as a specialist in this field, because I'm seeing more and more patients hop into care plans and programs that are designed to self-heal their concussions. And I'm finding them to be very cookie cutter, and I'm optimistic and happy they're getting care, but we have to be honest about our capabilities and know where our limitations are with regard to this type of care. We have to do the assessment at an extremely detailed level to really be able to offer patients constructive help in this area. It's extremely dense, of course. I included some useful research articles here that I think we call on frequently in terms of physiological findings. Like, we reference these a lot. So I wanted to include those if anyone wants to, copy and paste those links at a later time. I found them to be the most dense, but also useful. Like, patients can sift through it even without a medical background and really understand what's happening in those articles. So I reference them a lot. It looks like we are doing good on time. I think we're all set there, Gigi.
You are. That was amazing. That was really spectacular. I want to thank you so much for sharing such amazing case studies and your expertise. At this time, we will shift into our question and answer session. I'll put this back up on the screen, but I do also invite you to scan the QR code so that you can complete a survey of today's webinar. So while you're typing your questions, if you can take a minute to just scan the QR code, you just point your camera on your mobile phone to it, and then you can give us some feedback on the session. So we've got lots of questions coming through. I'll start with the first one. This is, do you have any experience with patients that have psychogenic seizures as a result of a concussion?
Yeah, so the answer is yes. Patients are in the classic Western medical categorization. They are really determined to be epileptiform and non-epileptiform activity. So when you go get your brain scan, right, if you're lucky enough to be able to have a seizure live for doctors to observe, we can determine whether or not it's epileptiform or non-epileptiform activity. We see a lot of patients classified under functional neurological disorder, or basically the medical community is telling them their seizure disorder is not from a known seizure activity that they can see on imaging, and that presents a lot of problems for them and a lot of confusion. And what we find on our end is there's really two buckets within that. We have patients that are having seizure-like activity, involuntary. I'm seeing reflexes happen constantly that are not in their control. And then we have another subset of patients that I have to help them get to neuropsych, because frankly, they are not having seizure activity. They think they're having seizure activity is kind of the most politically way to say that. So yes, the answer is yes. We see that very frequently. Just have to help them determine how voluntary that is on their end.
There was a follow-up question. It was, does the treatment differ?
Yeah, the treatment.
Okay.
Yeah, so the treatment is different for every single patient based on how they test. So we run always hundreds of tests on their first day if they can tolerate it, and that data will suggest various treatment plans. So I've had patients that have essentially a seizure upon standing, or they, have complete vasovagal failure, autonomic failure, and we have to keep them laying down the entire time and eyes closed. We've had everything in between that to the most athletic D1 pro athlete you can imagine. So treatment is always different.
Okay, thank you. Next question. In dealing with head injury, do you do any evaluation of how these treatments may improve cognition?
We do. So we do track cognitive performance and progress. There are several that we use both in-house and via app. You may know of EQ as well as Cambridge Brain Sciences. These are the most well recognized from a app perspective. We can send these to patients' phones, and they can do some self-assessments to notice the progress. It helps them track different aspects of visual spatial mapping, memory sequencing. There are cognitive dimensions that do help with balance. All of that is assessed on these apps. So we use those a lot for to really map cognitive progress. But we also, the treatments that we do in-house, because we're working on the hippocampus, the frontal areas, the motor planning, the metronome, as I discussed, those are proven to help with cognition. So we're getting benefits and boosts to care that's usually for, let's say, concussion pain, proper headaches, that is leveraged for those concussion, for the cognitive dimensions as well. So it's really cool to use both.
Okay, awesome. Next question. Can this type of stimulation result in seizures if the patient has a history of seizures? Yeah,
so I would just say, as a general arching theme, anytime you do, there is always a risk. So some patients are set off from their seizure for various reasons, like, for instance, optokinetic stimulation. I gave an example of the stripes moving on the screen on that one photo. That would be an example of a test we would skip, because if it's known contributions to seizure activity in a patient that already has seizures. There are patients that have seizures from hot and cold, changes to hot and cold, light turning on fluorescent light. So the degree to which we can manage and prevent seizure activity, of course we will. It is by all means the most safest metric we can use to, it's truly because we are so specific and so detailed and personal with every exam. There is no greater, safer place to be assessed with a proclivity for seizure activity than a facility like ours that is making it so individualized. But yes, the risk is always there.
Thanks. How long is the average treatment period?
Most of our patients are seen in what's called a neurointensive model or a intensive model. These are the neuroplastic research suggests that novelty. So we have to see our patients frequently with high intensity to make lasting plastic change. So what we do is design our treatment plans to be in an intensive format, which is usually 2 hours a day for a week. When someone is extremely autonomically compromised, we'll see them for 1 hour a day, usually for 2 weeks, still resulting in 10 hours of care. The amount of progress that patients make in those 2 weeks is substantial. It's usually significant, and it's usually noticeably different on the back end of that. We do lean on patients from there to do home exercises and continue to do the integration work that's necessary that's helped them improve so much. So it's hard to map that for you on, from a bird's eye view. I would say in-house treatments, the average is 1 week to 2 weeks.
Okay, thank you. All right, we are at time, and I want to be respectful of that for you. I do want to thank you again for participating and presenting on such a phenomenal topic and sharing the case studies. For those on the line, if you missed a session from this year, we do invite you to visit our website, medicalandlifecare.com/injury-insight-sessions. And you can access any of the 3 previous sessions, as well as scroll down to the bottom of the page and access sessions that we've hosted and produced over the last few years. With that, again, Dr. Helm, we want to say thank you. This was a wonderful webinar and our final one of 2023. Everyone, we do ask that you stay tuned for what's coming in 2024. Cindy, any final thoughts?
No, that was just great. That is exactly what we needed to see to just make this more concrete. So thanks again, Dr. Helm. That was wonderful.
You're welcome, Cindy. Thank you
All
so much.
right.
Talk to you soon.
Yes, thanks everyone for joining. Have a great afternoon.